So before we get started with today's program, I just wanted to remind everybody that next week's Grand Rounds is going to be the HADA lecture. And for that, we will have Dr. Stephen Choctaw, who is the professor in family medicine and psychiatry and biobehavioral science, and also serves as the vice chair for research in family medicine at UCLA Santa Monica Medical Center. The title of his talk is Medications as Foundation for Stimulant Use Disorder Treatment. Is it time? And hopefully we'll hear the answer to that question next week. And just as a reminder for today, at the end of the talk, we're going to prioritize questions from trainees during the session. We encourage everyone to post questions at any time during the talk, using the Q&A function at the bottom, which is separate from the chat. So please use the Q&A function. And if you are a trainee, please put the word trainee at the beginning of your question, and we'll know to prioritize those questions for our speaker today. So over to that. So today I would really like to extend a very warm welcome to Dr. John Pachankis. Dr. Pachankis is a Susan Dwight Bliss Associate Professor of Public Health and Psychiatry at Yale. He received his BA from Loyola University in New Orleans and then went on to receive his PhD in clinical psychology here at SUNY Stony Brook in New York. And following his clinical internship at McLean Hospital and Harvard Medical School, he joined faculty here at Yeshiva University in New York before moving to Yale, the School of Public Health in 2013, where he has since remained. So Dr. Pachankis currently serves as the director of Yale's LGBTQ Mental Health Initiative, which serves as a home for scholarship devoted to understanding and improving the mental health of LGBTQ populations in the US and around the world. He has served as a PI or a co-I on numerous NIH and foundation grants that examine the efficacy of LGBTQ-affirmative interventions delivered via diverse technologies, settings, and community members. These treatments have shown sustained reductions in depression, anxiety, suicidality, substance use disorders, and HIV risk across several randomized controlled trials. As a scholar, Dr. Pachankis has been incredibly prolific, publishing over 100 scientific papers on LGBTQ mental health and stigma-related issues in journals such as the Journal of Abnormal Psychology, Social Science and Medicine, Archives of Sexual Behavior, and JAMA Pediatrics. Most recently, he's published and co-edited the Handbook of Evidence-Based Mental Health Practice and Sexual and Gender Minorities, which was published by the Oxford University Press. And lastly, with such a body of work, the fact that he's received several awards for his research should come as no surprise, which this includes APA's Distinguished Contribution to Psychology in Public Interest Award and the Distinguished Contribution to Advancement of Psychotherapy Award, as well as awards for Distinguished Book and Distinguished Scientific Contribution to LGBTQ Scholarship. So today, the title of Dr. Pachankis' talk is LGBTQ-Affirmative Mental Health Care, from theory to trials to community implementation and global dissemination. And I cannot wait to listen to this talk. So please, again, join me in giving Dr. Pachankis a very warm welcome. And we thank you so much for being here with us today.
Thanks so much for that, that very nice and kind introduction. It's an honor to be here today to speak to you about perhaps the biggest challenge facing the LGBT community and possible solutions to this challenge that my research team at Yale has been investigating over the past several years. It's particularly exciting to be able to present here at Columbia because for almost 20 years, I've been doing this work in New York City. So it's always nice to get to share this work with audiences in New York City and at Columbia in particular, which is such a world leader in LGBTQ focused research and clinical care. So a sincere thanks for the invitation today. So the challenge that I alluded to is simply defined. LGBTQ people represent one of the highest risk groups for depression, anxiety, suicidality, substance use of any population risk group. And now that we have high quality, nationally representative data sets that assess sexual orientation and diverse gender identities, we know that study after study has shown LGBTQ people to be at about twice greater risk of these mental health outcomes than heterosexual cisgender populations, and sometimes those disparities are even greater. We know that this disparity peaks in late adolescence and young adulthood, and we know it largely persists across the life course. This has been true in nearly every data set in nearly every country in which this has been examined. So I want to address this challenge today broadly in two broad parts. The first will focus on the theoretical causes of this disparity, and the second will focus on solutions to this disparity, namely through my lab's clinical trials of LGBTQ-affirmative mental health treatments, and then efforts to implement those treatments and disseminate them in various settings worldwide. So for LGBTQ people, we know that the most plausible cause of the mental health disparity affecting this population is not biological or genetic, as some have argued, but rather societal-based stigma, or simply the societal conditions that lead some people to be actively devalued and have less power than others. Two prominent types of stigma are the discriminatory societal structures that surround many minoritized groups, called structural stigma, and the stressful or discriminatory day-to-day interactions with other people, including strangers, peers, coworkers, and even family, called interpersonal stigma. We'll start with structural stigma, which is defined by our colleague Mark Katzenbuehler as unjust laws, policies, and community attitudes that deny or fail to protect the equal rights of the stigmatized. However, until recently, structural stigma has been difficult to measure because it requires large samples of the LGBTQ population, which historically have been quite hard to come by, given that national and multinational governments and governmental agencies and health researchers didn't systematically collect information on sexual orientation and diverse gender identities until recently. The second challenge is that the LGBTQ sample be recruited from diverse structural contexts, rather than just one community or municipality in which everyone is ubiquitously exposed to the same structural stigma. I'm a psychologist, and a lot of psychological research takes place, you recruit samples from the same city, same town, or even same campus, which precludes the ability to look at diverse structural contexts and their potential influence on the mental health of any population. And then the third challenge is that you need a quantitative approach to measuring structural stigma in order to estimate its downstream impacts on any outcome. So such a quantitative index at the country level might look like this, where you can sum each country's presence or absence of discriminatory, criminalizing, or on the other flip side, protective laws and policies like those listed on this slide. So this objective approach to measuring stigma also overcomes the more commonly used subjective measurements of stigma, which are subject to self-report bias, in which two people can report very different experiences of the same exact event. It also overcomes same source reporting bias, whereby the predictor and outcome are measured using the same approach, which is particularly problematic when the predictor is stress and the outcome is mental health, because it can lead to inflated estimates of the associations between those two things when you assess them using the same modality from the same person. So taking that index, the quantitative index of structural stigma that I showed on the previous slide, you can then take such an index and apply it to a suitable data opportunity. So the European Union LGBT survey provides one such opportunity and allows us to overcome the challenges that have typically impeded assessing the association between structural stigma and LGBTQ people towards LGBTQ people and LGBTQ people's mental health. It's one of the largest, if not the largest, surveys of LGBTQ people, containing over 90,000 participants administered in 27 languages across the 28 countries. There's another quite similar data set called the European Men Who Have Sex with Men Internet Survey. It's limited to men who have sex with men, but similarly, it recruits participants across, well, actually in that case, 44 countries across 33 languages, and includes over 100,000 people. So using these data sets, we find a strong association between country-level structural stigma and towards LGBTQ people and LGBTQ people's odds of depression. So this association, importantly, exists even after controlling for the prevalence of depression in the general population, whereby people in Ukraine are likely to be more depressed than people in the Netherlands in general. So even when you control for the average population's risk of depression in each country, what you see on this figure is that structural stigma towards LGBTQ people predicts odds of depression even over and above country level and other country level influences on depression. So you see this pretty strong linear association between structural stigma on the x-axis, with countries like Ukraine, Belarus, Lebanon, Turkey being high in structural stigma, compared to you see about half the odds of depression among LGBTQ people in countries like Denmark, the Netherlands, Luxembourg, and Sweden. The same is true of suicidality, with about 15% of LGBTQ people in the Netherlands reporting past year suicidality on the patient health questionnaire, whereas twice that percent of LGBTQ respondents report past year suicidality in more structurally supportive countries like Ukraine. And what this shows us really is that geography is really is very important. For the health and well-being of LGBTQ people, even over and above the importance of geography for the health of all populations. So what you have basically, at least in Europe, or you have neighboring countries like Russia and Finland, or Russia and Sweden, where the odds of suicidality or depression are about twice as great, even in the more stigmatizing neighboring country, compared to the more supportive country just on the other side of the border. So now I'll present evidence that interpersonal stigma, including stressful interactions with parents and peers due to one's LGBTQ status, predict the mental health outcomes that I showed earlier as known to disproportionately affect LGBTQ people. But the search for these interpersonal forms of stigma has to start early, because we know that many young LGBTQ people experience mental health challenges. But how young the disparities in those challenges start, and how the size of that disparity compared to heterosexual cisgender young people is still relatively unclear, largely because of the challenges of studying these topics among very young people. So my colleague Dan Klein at SUNY Stony Brook, starting actually when I started grad school in 2002, started following a group of about 600 youth since they were age 3 on Long Island, New York. And every 3 years since then, the kids and their parents and teachers have completed numerous assessments of their health, of their well-being, and of their temperamental vulnerabilities and social vulnerabilities to things like depression and anxiety. So we started asking the youth in this prospective cohort study at age 15 what gender they were attracted to. This allowed us to identify who was probably a sexual minority in terms of the gender or genders to which they reported being attracted. About 11% of the sample did report same gender attractions, and in their lives, we see that they had experienced a steep relative risk of depression compared to the youth who said they were only attracted to people of the other gender. And we see that disparity starting from a pretty early age, becoming quite pronounced by high school. By high school, we also see that many more of the youth reported same-gender attractions, reported poor relationships with their parents, and more bullying compared to youth who only reported other gender attractions. In fact, the association between sexual orientation and age 15 depression was significantly mediated by age 12 exposure to poor parental relationships and to bullying. So these results highlight the potential role of interpersonal stigma from parents and peers in LGBTQ people's in the emergence of LGBTQ people's disproportionate risk of depression. We find a similar role of peer bullying in LGBTQ youth suicide. So Dr. Kirsty Clark, one of my former students and now current colleagues, an assistant professor at Vanderbilt, was particularly interested in whether bullying might cause the much greater rate of suicide we see among LGBT young people. So she asked the CDC if she could analyze the US death records related to suicide. So the National Violent Death Reporting Survey compiles a record of all US suicides using death certificates, coroner and medical reports, and law enforcement reports. And this provides a pretty unique and very valuable context in which to study suicide and the factors that surrounded that suicide. Such data are quite comprehensive and more so than a lot of other resources for determining the context of youth suicide. So what she and another student of mine did was review all the death records for youth suicidality from 2003 to 2017 in the NVDRS, and compared the frequency of bullying in those death records in terms of whether the youth was classified as LGBTQ or whether the youth was whether the youth was not classified as LGBTQ. the existence of bullying and the existence of an LGBTQ status was derived by systematically coding the death records in the National Violent Death Reporting Survey for both of those things. And what they found was that the records of LGBTQ youth who had died by suicide showed 5 times the odds of being bullied compared to the death records of youth who had died by suicide who were not classified as LGBTQ. This was especially true for the 10 to 13-year-olds, providing strong evidence for the role of bullying, not just in depression, but even for life itself for youth in the US. So these findings regarding structural and interpersonal forms of stigma support the basic tenets of what's known as minority stress theory, which suggests that the cause of the sexual and gender minority disparity in mental health and related outcomes is a function of LGBTQ people's greater exposure to structural and interpersonal stigma. Another key part of minority stress theory is that these forms of stigma give rise to reactions, to coping reactions, both maladaptive and adaptive coping reactions that serve as mediators of the link between stigma, things like bullying, parental rejection, structural stigma, and the mental health outcomes that we've discussed. So one of these reactions, and one that I've spent much of my career studying, is identity concealment. So because they possess a relatively concealable identity that's stigmatized, LGBTQ people face the choice of whether or not to come out. And although models of stigma concealment suggest that the environment ultimately determines, whether an LGBT person perceives that it's safe or not to come out and what the relative cost and benefits to coming out versus concealment might be, very few studies have actually examined the environment as a determinant of concealment. So using those same large cross-country EU data sets that I mentioned earlier, we find that in countries like the UK that scored low on the structural stigma index, the vast majority, you can look at the slide, the vast majority, like 90% of the sexual minorities in those countries report being out. Whereas in countries like Romania, a country I'll actually talk more about towards the end of the talk, that scored high on the structural stigma index, the majority of sexual minorities are in the closet, suggesting very wide variation in concealment as a function of country-level structural stigma. When you look at gender minorities and ask trans and non-binary people about their identity disclosure as a function of structural stigma, you see a very similar pattern of results. And we find that concealment statistically mediates the association between structural stigma and suicidality. The reason we ask these research questions are, what is it about structural stigma that gets under the skin to lead people, LGBTQ people, to be more suicidal, more depressed? What is it that's shaping their day-to-day reality that makes life, that makes life a burden? And what we see here is that, when someone, when the majority of a country's population is concealing their sexual identity, as a function of the structural stigma and the surroundings of that country, you see that the way people live their lives, in terms of the basic things they share about themselves, who they surround themselves with, how open they are, how much they silence themselves versus fully expressing their authentic selves. These are day-to-day processes that plausibly do get under the skin to drive things like suicidality and depression. And we see that in fact is the case. So then we looked at another minority stress reaction called internalized stigma or internalized heterosexism, internalized transphobia. This is the direction of negative societal attitudes about LGBTQ people towards oneself. And we found a similar association with structural stigma. So keep in mind that that this is one of the few data opportunities that permits this test that was conducted across numerous studies and that actually assessed minority stress reactions like concealment and like internalized stigma. And similarly, like we saw for identity concealment, we also see that the association between structural stigma and depression and suicidality is mediated by internalized stigma. We find the same for social isolation, which is another minority stress reaction. And we find a similar pattern for structural stigma, for social isolation's mediating role in the association between structural stigma and depression and suicidality. So remember that studies that use this objective measure of structural stigma help strengthen causal inference of the role of structural stigma in driving these outcomes, because mental health and these mediators like social isolation can't cause structural stigma, and there's no strong evidence for differential migration by mental health status, whereby people with poor mental health move into countries with higher structural stigma. We don't see that in the data. There's not strong evidence for that, which lends confidence in our attribution of some causal role of structural stigma in these downstream mental health outcomes. So another final mediator I'll review is what's called rejection sensitivity. Rejection sensitivity refers to chronic anxious expectations of rejection or hypervigilance for LGBTQ-related rejection. So this particular minority stress reaction is operated to actually emerge as a function of interpersonal rejection, because rejection sensitivity is assumed to operate like an interpersonal schema that emerges from interpersonal experiences of minority stress, like parental rejection, discrimination, bullying. And in fact, across studies, we find evidence that rejection sensitivity mediates the association between interpersonal exposures like discrimination and mental health outcomes like depression. So overall, the results I reviewed support the tenets of minority stress theory. Structural and interpersonal forms of stigma are strongly associated with poor mental health, and this association is mediated by minority stress reactions that lead LGBTQ people to hide their true selves, to feel ashamed, to feel isolated, to expect rejection on a chronic, everyday basis. At the same time, because they all represent cognitive, affective, because those minority stress reactions all represent cognitive, affective, and behavioral reactions within the person, these reactions can be affirmatively addressed through psychotherapy. Now, the onus of change obviously should be on the structural context that ultimately drive the need for these reactions, and that ultimately drive the mental health disparities that we see. At the same time, because stigma drives cognitive, affective, and behavioral reactions within the person, theoretically, we can empower individuals to also cope with or resist the unfortunate impact that stigma can have on mental health. Yet until recently, no empirically supported mental health treatment had been created to address these reactions. And in fact, until recently, very few mental health treatments had ever been examined in RCTs, specifically for LGBTQ people. So therefore, over the past several years, our team at Yale has been working with numerous colleagues at other universities and numerous members of the local LGBT community to develop and test the efficacy of an intervention approach that affirmatively responds to stigma and that addresses minority stress reactions to improve mental health. So ideally, such an intervention would provide clinicians with guidance for sensitively and affirmatively responding to clients who present LGBTQ-related stressors, like the one on the video I'll show now. Ideally, the results of these trials would be able to tell clinicians how they should respond in this type of clinical situation, what they can do affirmatively and sensitively to support clients who end up in this type of situation. In this way, the results of these trials would be a set of principles or techniques or a framework for affirmatively addressing LGBTQ people's presenting concerns in general, and especially those that emerge from LGBTQ related minority stress and related reactions, as we've shown, underlies the disparity, most likely underlies the disparity in these mental health problems. So here's an example client, an actor who's role playing a script of a client that we've seen in our trials.
It's been a rough past few months. I guess that's why I'm here. But honestly, it's always been like this. My parents always telling me that they don't understand me, and when I explain to them that I'm queer, it turns into this huge argument. It's probably why I'm not out to most of my family, but you know, it's one thing to not be supported by your family, but then to be told by the queer community that you're not queer enough. It's why I avoid getting involved with relationships and having conversations with most people. And when I have conversations, I end up feeling like I've done something wrong. And they just realize that I'm the bad guy. And even when I'm by myself, you know, it's this voice in my head constantly telling me that I'm not good enough.
So to create a treatment that would be able to provide the community of mental health practitioners with guidance for how to affirmatively address minority stress reactions and be able to assess minority stress reactions even in clinical practice. We first, this was many years ago, we interviewed numerous mental health providers around the country, those who had spent their entire careers working with LGBTQ people. And we asked them how we should adapt cognitive behavioral therapy to best support LGBTQ individuals' mental health. And so we started with CBT because of the kind of logical fit between the cognitive, affective, and behavioral nature of these minority stress reactions and CBT's approach of locating presenting problems within the maintaining environment, promoting coping, self-efficacy, etc. CBT was a logical fit. It certainly doesn't mean it's the only treatment platform that these types of principles could or should be applied to. We also met with dozens of LGBTQ people themselves who were experiencing elevated levels of depression, anxiety, suicidality, substance use. And the mental health professionals that we interviewed told us about the ways they've seen LGBTQ people grow past the painful experiences of stigma by first acknowledging the pain, often in psychotherapy, and then learning ways to stand up to stigma, especially as it manifests within oneself, and learning new empowered ways of thinking and acting, and finding support, meaning, and purpose within the LGBT community as they do so. So we packaged all of these research findings, these stories, and this professional wisdom into a CBT treatment manual that provides LGBTQ young people with the tools to understand and challenge the ways that minority stress manifests in their lives and the impact of minority stress on their mental health. So the community members we met with approved of the treatment manual and protocol that we put together, and suggested a few other ways to improve it to best meet their clients' needs. And then we ran it again by the community members we met with for their further input. And then we took all of that community wisdom and packaged it into a final treatment manual and tested the treatment's efficacy in an initial randomized controlled trial. So until this research, no mental health treatment for LGBTQ people had been tested in a randomized controlled trial to see if it worked. So before showing the results of this first trial, I'll review the principles and techniques that help the CBT-based treatment respond to minority stress, and that can serve as a framework for adapting many types of evidence-based treatment to be LGBTQ affirmative. So first, many LGBTQ people started a baseline of blaming themselves for their failure to successfully cope. But they don't often acknowledge the barriers that LGBTQ people face to successful and healthy coping. So, borrowing from work in the 1970s with the women's movement, we use consciousness raising exercises that increase LGBTQ people's awareness of stigma-related stress and the ways that it can lead them to blame themselves and even the LGBT community as the problem, rather than placing the problem on exposure to stigma. We also teach, the treatment also teaches LGBTQ people skills for reducing the avoidant coping strategies that they might have learned. Things like social isolation and self-harm, which we know are disproportionately common in LGBTQ people. And drawing on the literature and the stories we've heard, that these avoidance strategies often serve as a way of finding meaning or purpose or connection that often seems elusive in heterosexual cisgender society. Unfortunately, sometimes these avoidance patterns become so severe that people stop knowing what they feel, or they turn to alcohol, drugs, and risky sex to numb their painful feelings or to find meaning. Nearly all of the experts we spoke to noted the ways that their LGBTQ clients have a much harder time than their heterosexual cisgender clients asserting themselves, asking for what they need, being themselves in their day-to-day lives, expressing their authentic voice. So, we have participants in our RCTs who don't believe they have the right to be out to their friends or families or their coworkers. Some have spent their entire lives closeted, to use one example of a minority stress reaction. So we work with them on weighing whether the benefits of living authentically outweigh the cost of concealment. And for many people, that is a difficult that's a difficult calculus to make. But we support them in making that decision after we've helped them understand the cost and benefits of the decision. So a lifetime of stigma can also cause cognitive biases, such as constantly expecting rejection or believing, especially implicitly, in one's inferiority, in one's lack of validness in the world, in one's unlovableness. So we rework these cognitive biases by helping the people in our study do things like learn that they're worthy of love and acceptance, despite the painful lessons of stigma. So again, across all the CBT techniques that are included in the manual, and these are just basic CBT techniques that are familiar to most people in the audience. We've adapted all of those techniques to respond to the connection of these mental health outcomes to these minority stress reactions, and to help clients see those connections. One is a way to empower them to be motivated to take care of their mental health, but also given study after study shows that these are in fact the mechanisms that underlie the disparity that disproportionately brings LGBTQ people to treatment. And then finally, given the structures that keep LGBTQ people away from support and guidance, we also help, the treatment also helps people find a supportive, meaningful niche within the LGBT community. Many young people, like in our studies in New York, will say that they don't have much connection to the LGBT community, or they'll have a negative view of it, kind of expecting that when they came out or when they moved to New York, that they would be given an LGBT community, it would come ready packaged, and that they would have a home within that community. Instead, the treatment helps them recognize instead that the building community is an intentional action that takes work, that takes commitment, and that takes time, but that can be done with that effort. So we teach people these cognitive, emotional, and behavioral skills to help them start overcoming the painful lessons of the painful ways of thinking and behaving that many of them have held on to for their entire lives since they first had an awareness that they were different, and that unfortunately set them up for mental health risk starting at an early age and persisting across much of the life course. So we in the first trial that we conducted, and the treatment's now called EQUIP, which stands for Empowering Queer Identities in Psychotherapy. We delivered the treatment across 10 sessions, one-on-one, to 63 young gay and bisexual men in New York City. the study was funded by an HIV mechanism at NIMH. So it focused on young gay and bisexual men who are at risk of HIV infection and who are also depressed and anxious. So looking at the lines in blue compared to the line in gray, which shows the outcomes from the wait list, we found that the treatment helped the men in the study feel less depressed, less anxious, drink less, have safer sex, compared to the waitlist group. We then asked whether this treatment might be more efficacious than existing treatments for LGBTQ people. So in a trial with 254 young gay and bisexual men in New York City and Miami, we compared this equipped treatment to LGBTQ-affirmative supportive counseling in the community and single session HIV testing and counseling, like a 30-minute HIV testing and counseling intervention. And we found that the treatment was largely similar compared to those two other treatments when we examined single outcomes. Although you'll see that some of the effect sizes, especially for some of the effect sizes, including for substance abuse, were actually pretty robust and strong. But the strongest efficacy, comparative efficacy of equip compared to those other two conditions was actually for comorbidity across the conditions, given that. Which is kind of consistent with the trans-diagnostic basis of the treatment that targets minority stress mechanisms that are theorized to underlie all of LGBTQ people's disproportionate exposure to mental, behavioral, and sexual health risks. And also, as I'll review shortly, the equipped treatment, because it's manualized and organized around a set of principles and techniques, it lends itself to broad dissemination. So these initial trials were conducted only with men. And one positive outcome, if you will, of the HIV epidemic is that it at least brought greater research attention to sexual minority health in the 1990s. Yet still today, about 3/4 of the NIH portfolio for sexual minority health research is devoted to studying HIV among gay and bisexual men. And at least partly for that reason, that imbalance is also reflected in the two interventions that I just presented. So my lab's also made a concerted effort to expand our intervention research to sexual minority women and transgender individuals. So for instance, we delivered the treatment to 60, we delivered an adapted version of the treatment after deep consultation with sexual minority women who were at risk of mental health difficulties and providers who were experts in treating sexual minority women's mental health. We conducted a waitlist control trial in New York City with 60 young queer women. You can see that the sample is quite diverse with regard to sexual orientation and gender identity. And similar to the pilot study with young gay and bisexual men, we found that compared to waitlist, the treatment was associated with significantly greater reductions in depression and anxiety and unhealthy alcohol use. And Tonda Hughes and I, Tonda's, as you all know, is at Columbia in the School of Nursing. She and I have kind of joined forces to continue this work, building on her many decades of research with sexual minority women to test this treatment in a much larger randomized control trial with sexual minority women who are at risk of alcohol use and depression. So my team is now studying whether the treatment can also lend itself to more efficient reach by using an asynchronous form of the treatment, whereby LGBTQ young people anywhere in the US can receive 10 sessions of the psychoeducational content related to minority stress reactions and CBT skills for addressing those reactions and its emotional impact. They can read this material online, complete and share written reactions, and try out the CBT skills in their lives. And the neat thing about this particular form of asynchronous delivery is that a therapist still reviews the client's engagement with the program, their written exercises, their homework practice, and but it requires much less therapist time than a one-on-one meeting, hour-long meeting with the therapist every week, such that therapist caseloads with this type of treatment can be in the several hundreds, 200-300 participants at a time. So we're in the process of comparing this treatment to simple weekly self-monitoring, and we'll eventually compare it to the more time-intensive standard, hour-a-week one-on-one intensive deliveries that are more commonly used and that have been used in our trials to date. So this will allow us to weigh the relative benefits of this delivery modality, which is capable of wider reach. So speaking of reach, I'll highlight our team's efforts to ensure that the implementation of this effective treatment can reach our local communities and ensure that it responds to the needs of those communities. So we know that LGBTQ identities don't exist in isolation, but they rather co-occur with other identities. We also know that if current rates continue, a Black gay man in the US has a 1 in 2 chance of becoming HIV positive in his lifetime. We also know that a Latinx gay man in the US has like a 1 in 3, 1 in 4 chance of becoming HIV positive in his lifetime for no other reason than intersecting sources of structural discrimination towards LGBTQ people and towards people of color. Further, we also know that the fastest increases in new incident cases in the US are occurring among Black and Latinx gay and bisexual men in small urban areas, mostly places in the Deep South, places like Jacksonville, Shreveport, Louisiana, Birmingham, et cetera, but also here in the Northeast in New Haven, Connecticut. So I was approached by a medical provider who's working at a federally qualified healthcare center in New Haven who was witnessing that epidemic firsthand. So she reached out to me to see if we could implement our intervention at her clinic to address the intersecting forms of racial and sexuality-related stigma facing her patients, and to do so in a group-based delivery format, given that it's more efficient, but that it also brings community members together, which may have a curative impact. So a psychologist in my lab, Dr. Skylar Jackson, and I therefore worked to do just this. So our team conducted about a dozen interviews with gay and bisexual men of color in the local New Haven community to get a sense of their interlocking forms of stigma and how they influence mental health, HIV risk, sense of community, and connection. We then packaged the results of those findings into the EQUIP intervention material so that it responded to these intersectional realities, including in the manual and the handouts. And then we then delivered the treatment to 21 Black and Latinx gay and bisexual men at the Fairhaven Community Health Center. And in this small pilot, we found reductions in the expected direction for most of the outcomes. There were 21 people in the study, so there's only so much you can do statistically. But we did see a pretty clear pattern of feasibility and acceptability of the intervention, and the fact that the vast majority of participants attended in the majority of sessions also speaks to its feasibility, including in a group-based delivery. And also we saw that the intervention has a strong impact on the men themselves, as illustrated in their own words. So here's how the men in the study said the program helped them. One said, I used to think that being gay was a bad thing and that I should be ashamed of myself, that I should try and be straight and that I shouldn't hang out with like other gay people. Now it's like the exact opposite. Another said, after the study, I came out to my mom. I came out to a lot more friends. Now I'm just living my best life, as people say. Another participant said, it helped me a lot to, how do I say it, be happy with myself, like accept myself. People actually listened and cared about what I had to say. And so the treatment really helped strengthen their identities as gay and bisexual men. And many participants reported a simple but impactful takeaway pretty consistently, namely that they felt like for the first time that they weren't alone, highlighting the impact of the group-based adaptation delivered to Black and Latinx guys in the New Haven community. So with the goal of assessing whether the EQUIP treatment could be implemented in community settings across the country, we identified an ideal network of such settings where this could happen. Specifically, the US has more than 250 LGBTQ community centers, about 40% of which provide mental health services to combined like 30, I think the recent data show closer to 40,000 LGBTQ people each year. Because LGBT community centers offer free or heavily subsidized mental health services, they typically provide access to those who might not otherwise be able to receive such care, including individuals with lower income and LGBTQ people of color. So we specifically partnered with Centerlink, which is the coordinating hub of the 250 LGBTQ centers in the US, to survey the directors and CEOs of these centers to assess their capacity to implement the EQUIP intervention. And as you can see, most of the directors we interviewed reported room to improve their mental health services. Most also reported that their staff could benefit from training in the treatment. And all of the directors said that they would provide the administrative support necessary for their mental health staff to be trained in the equip treatment. So we trained them. But not only that, we used implementation science to determine whether our training was efficacious. So specifically, we've basically wrapped up a waitlist controlled trial of an 11-week training in equip to 130 mental health providers working in LGBTQ centers across 21 US states. So what we did was, like, every Friday from 12 to 1, we hosted a lunchtime webinar where that administered continuing education credits to these 130 people, and the 4 of us here on the side paired up each week to take one of the modules of equip and train the attendees in the module. And almost everyone attended almost every session, which was promising. And because we were doing this in LGBT community centers, I initially thought, well, there's only so much room that these providers could grow in terms of their LGBTQ affirmation. Maybe we'll be able to teach them CBT skills that they didn't have before. Maybe we'll be able to teach them how to use CBT to respond to minority stress. But even their cultural competence in working with LGBTQ people significantly increased from before to after the training compared to the waitlist. So we did this twice. Half of the people we delivered over 11 weeks sequentially before we then did the same with the people who were initially on the 4-month waitlist. And what we see from our interim analyses that we just conducted was that the training was associated with significantly greater increases in LGBTQ affirmative cultural competence, knowledge of minority stress theory, familiarity with the equip skills, and use of the equip skills in practice. We're also in the process of, actually, we just finished coding the providers' responses to a simulated practice assessment, whereby we hired LGBTQ actors in California, like the woman in the tape that I showed earlier, to role play being clients based on a script that we gave them from our trials. And then we asked the participants in the training to describe exactly how they would treat that person, so we could assess their uptake of the equip skills as codified in the manual and training materials. And what we saw was that the training was associated with significant uptake of actually demonstrated equip skills from before to after the treatment compared to the waitlist. In response to those, we created 4 videos across the 4 videos. So finally, we want to know whether this treatment can be disseminated to other high need, high stigma settings. So first, we're working with our colleagues in Changsha, China, in Hunan province, to adapt the equip treatment to respond to the intersections of Chinese culture and LGBTQ identities there. So following all the steps of the adapted model, which is one of these kind of eight-step approaches to culturally adapting a behavioral intervention to match the needs of any setting. We went through, over about a year or so, went through that process in those 8 steps to ensure that the resulting treatment was appropriate and resonant with young gay and bisexual men living in Hunan province. So this included meeting with experts, demonstrating the treatment in front of a community audience, training the therapist, and doing a small open trial with with eight people to at least show that the therapist could deliver the treatment with fidelity. And we also happened to assess the session by session improvement, depression, and anxiety, which we saw change in the expected direction. So we're now testing this adapted treatment using that asynchronous delivery modality that I showed earlier in an RCT with 120 young gay and bisexual men in Changsha. Another side of our work is Romania, a place that I've gotten to know a lot about over the past 10 years with my good colleague, Karina Labuțiu-Weinberger at Rutgers. And Karina is Romanian American, lives in New York, and Romania is has about the most normative anti-LGBTQ attitudes and policies of any European country. So like it's one of those countries where identity concealment is the norm, and where LGBTQ affirmative mental health services are largely lacking. So Karina and I had been conducting RCTs of mental and sexual health interventions there for young gay and bisexual men. But at the same time, we were noticing a real lack of structural supports. We were providing support to these individuals, but at the same time, there were very few places where people could get affirmative STI screening, or appropriate STI screening, or very few places where people could continue mental health care with LGBTQ affirmative providers. So what we did was we trained nearly 200 mental health providers to deliver LGBTQ affirmative therapy. And in this trial, we compared our 10-hour in-person training to a 10-hour remote training to see whether we could in fact train people from afar just as efficaciously as training people in person, which has an important implication for dissemination of training, right? If you don't have, Karina and I have been to Romania probably 12, 13 times over the years, but if but it takes a lot of time and a lot of resources to be able to do that. If we found that we could train people from afar just as easily, we could extend this approach to other countries, including in the Central Europe, Eastern European region, that have many of which have a similar state of affairs towards LGBTQ people as Romania. And in fact, what we found is that whether the training was delivered in person or remotely, the participants experienced significant reductions in explicitly measured LGBTQ related bias. We gave participants the IAT, or the implicit associations task, to measure implicit bias. We also saw an improvement in LGBT affirmative practice skills, practice beliefs, practice behaviors, and practice intentions. And there was and there was no significant difference depending on, as you can see from the effect sizes here, depending on whether the training happened in person or remotely. Sorry. So I'll finish by summarizing two research questions that our lab is currently pursuing to further optimize evidence-based mental health interventions for LGBTQ people, and to ensure that they reach those most in need with the tools that they could perhaps benefit from. So the first of these questions is how and why do these LGBTQ affirmative treatments work? Well, we started answering this question by simply just looking at pre-post changes in outcomes and mechanisms in our EQUIP pilot studies. And you see that the treatments associated with some improvements in minority stress reactions, like concealment, like rejection sensitivity, as well as in the universal risks for depression and anxiety that LGBTQ people are disproportionately experiencing. Things like social support, emotion regulation, assertiveness. But we need to do this in our larger trials that have more people and that follow people prospectively over several follow-up points. In the case of the large trial, we followed people for a year at four follow-up periods, which actually allows to see whether engagement of these mechanisms precedes and predicts improvement from the treatment. And then finally, knowing for whom our minority stress-focused affirmative treatments work best can help us know who might particularly benefit from this type of treatment, more so than other treatments maybe. So we started searching for such moderators of treatment effects across individual, interpersonal, and structural levels of stigma. So I'll show you the outcomes for the individual stigma and then the structural stigma as moderators. So in that first weightless control trial with 63 young gay and bisexual men, we gave them the IAT to assess implicit internalized homonegativity, basically how much they associated gay with gay or bisexual with bad versus gay or bisexual with good. And what we found was that clients who reported more implicit internalized homonegativity on the IAT responded more strongly to the treatment across these outcomes. And working with Mark Katzenbuehler and some other colleagues, we've also started looking at whether structural stigma moderates the efficacy of of the treatment as well. So, that large trial was conducted in New York City and Miami. So again, ubiquitous exposure in terms of where people currently live. But the participants in that study have hometowns or grew up all over the US and other countries in the world, especially in the case of the participants in Miami. So what we were able to do is look at whether structural stigma of one's hometown moderated the efficacy of the intervention. And what we see is that is in fact that structural stigma might impair the ability of clients to benefit from the treatment. So why this might be the case and how the treatment might need to be adapted for those from high stigma, high structural stigma places represents an important direction that we're currently pursuing. This also links intervention science with the science of stigma, especially structural stigma, in a way that that hasn't been typically done. So, in conclusion, from the beginning of the LGBTQ rights movement, one of the demands of the LGBT community was an affirmative approach to mental health. Keep in mind, the mental health profession up until that point had been used to pathologize people with diagnoses and labels and psychologically, if not physically, abusive treatments. The field of psychiatry was used for harm towards this population. And so it wasn't lost on early LGBTQ rights activists that using the profession of psychiatry to acknowledge the legitimacy, to affirm the legitimacy of this population, not only that, but to actually support the population and the damage that it had suffered was a basic request and a reasonable request. And so I end on this note that the mental health field has come a long way from basically condemning LGBTQ people to lives of solitude and sickness to actually, developing and testing and delivering LGBTQ affirmative treatments, conducting research showing that those treatments are effective and implementing those in places where LGBTQ people remain in quite high need. And it's important for an audience of mental health professionals to realize the responsibility that they have to respond affirmatively to the needs of that community to continue to ensure its equality and thriving. So in conclusion, I want to obviously thank you all for showing up today and your support of this topic. The research I presented here is the result of the hard work of a lot of committed, caring people, some of whom are shown here, the members of the current team. And others who are shown here. So I want to thank them and the many collaborators, students, colleagues, and funding of this work, without whom none of this would be possible. So thank you again for attending, and I look forward to hearing your questions and engaging in discussion.
Thank you, John, for that wonderful presentation. And just to paraphrase Tonda Hughes, who left a lovely message in the chat. She says, incredible work and a wonderful presentation of a broad and highly impactful program of research. So we have a few questions from the audience. So I'm just going to start to go through some of those. One question, just sort of a clarification, but I think also invites broader discussion about the data. So the data sets that you presented when you were looking at structural stigma and depression were from 2 European databases, and as such, the countries were all in Europe. Is there anything similar for the United States? And can you tell us a little bit about that?
Yeah, I can. So Europe's interesting because of the sheer diversity of context. It really is a patchwork of support or not for LGBTQ people, and basically neighboring situations, neighboring countries that are in many ways, in many examples, highly distinct from each other. The U.S. is also a patchwork of kind of laws and policies and support, and obviously the work of Mark Katzenbuehler has shown that using kind of some nice triangulated methods from including quasi experiments, showing that a very plausible case that the structural stigma surrounding LGBTQ people is, has an impact on LGBTQ people's mental health. That seems to be particularly true for depression and anxiety. I think the effects are probably somewhat weaker for substance use and HIV risk, because those things are so multi-determined. And there are various mechanisms that might explain structural stigma's impact on those outcomes versus depression and anxiety. But yes, the case can be made that the association between structural stigma and mental health is robust in the US. What has been harder in the US to come by are data sets that include measures of those mechanisms. So the European Union commissioned these large surveys to get a sense of the fundamental rights situations of LGBTQ people living on the European continent. And as part of that, people advocated for the inclusion of tests of these mechanisms that are part of minority stress theory. Things like concealment, things like internalized homophobia, things like social isolation. But that's been harder in the US. Those data sets are rare, but there is one data set that called the NSASH, the National Study of Structural Stigma and Health, led by Mark Katzenbuehler and Brian Dodge, that has shown pretty robust associations between state level, country level, and municipality level structural stigma on at least gay and bisexual men's odds of concealment.
Great, thank you. And related to that, a couple of questions in this line. Expanding upon the idea of even within a smaller country or particularly within the US, while you may have a countrywide index for structural stigma, within that country, the laws that govern don't necessarily translate to the way various communities may interact with each other and with their LGBTQ community members. So I'm just questions regarding whether or not you've looked at that intersection of sort of structural stigma and how it may interlay over sort of community membership, whether it be religious or a particular cultural community, and then how that in turn impacts either internalized stigma or mental health outcomes.
Yeah, it's a fantastic question. So you can approach this question of intersectional. I guess this is ultimately a question of intersectionality and intersectional exposures. And one, using that European MSM Internet Survey data set, we realized that that LGBTQ people are surrounded by not only laws and policies towards LGBTQ people, but also laws and policies that affect other minoritized populations. In Europe, a prominent minoritized population is people who have migrated to Europe from outside of Europe. And so, and the European Social Survey assesses the attitudes of a representative sample of people living in each European country towards immigrants. I forget what the exact question is, but it's basically, whether these people are biased against immigrants or not. And so what we did was use that as an index that aggregated with laws and policies towards immigration that vary widely across the European countries, and looked at that in like statistical interaction with structural stigma towards LGBTQ people, to look at the associations that intersection has on in that case, HIV, on the sexual health of gay and bisexual migrants to Europe. And the pattern of associations is pretty clear, and that's that if you're a gay or bisexual male migrant who moves to a country that includes high anti-immigrant stigma and high anti-LGBTQ stigma, that your odds are that your sexual health is worse off than if you move to a country with only one of those or neither of those. But there are many other ways of looking at this question of intersectionality. Skylar Jackson, a colleague of mine here at Yale, whose work I mentioned earlier, is doing this using that NSASH data set, looking at the intersection of structural racism with structural heterosexism in the US to predict mental and sexual health outcomes among Black and Latinx gay and bisexual men in the US. But otherwise it is an open area of research to look at personal, how one's personal identities intersect with the protections or lack thereof available and the geographies where they live. I see that as a really important area for future research that I hope people run with.
Great. And then sort of relatedly, we have a question from Cristiani Duarte. Said, excellent talk, thinking about your basic model and decision of how to intervene for some of the mediators and mechanisms. So for example, social isolation, distress may not actually be present. In this case, should we still be thinking about an individual level psychological intervention? And even if the intervention can work, what would motivate people to seek this type of care if they're not experiencing distress, but still suffering the consequences of structural stigma?
Yeah, it's an excellent question that gets at it really one of that gets at the heart of the challenge of being a psychologist dealing with the population disparity that's ultimately driven by things outside of the person, right? Outside of the person who's presenting to you. And so the question specifically was how to how to approach someone with a clinical lens on minority stress if they themselves aren't presenting with that type of concern. Yeah, I hope that the results of this work can be a contribution to the growing body of work of how clinicians should respond to any LGBTQ person who presents to them. There are many clinicians who who are at a loss for for the needs of this community. The principles applying this treatment to everyone, to every LGBTQ person all the time, regardless of how they see their own concerns, would probably not be ideal, and it probably wouldn't even be particularly affirmative, because part of affirmative therapy, thinking of the American Psychological Association's guidelines for affirmative psychotherapy, it's you don't make someone's sexual orientation or gender identity the focus of treatment when it's not. And so, but part of an accurate assessment, and something that I do think often is missed by people who don't think in terms of practitioners who aren't necessarily thinking in terms of minority stress lens, is how subtle the impact and how implicit the impact of a lifetime of stigma exposure can be on someone's internal psychology. And that does take some careful assessment to decide with the client whether and how relevant minority stress might be to their lives. I will say that in the treatment studies we've done, and it's a biased sample because these are people who have presented to treatment and they suspect what the treatment is. The vast majority of people in the study can tell you so many ways that minority stress impacts their lives. We're doing a study with young LGBTQ youth right now, a group-based treatment, and last week we just had the session on consciousness raising about minority stress. There was no shortage of ways that these young people could talk about, and this is in 2021, right? In the Northeast US, there was no shortage of ways that people could talk about the impact of minority stress on their sense of self and on their mental health. But at the same time, it does take careful assessment to ensure that it doesn't become the focus of treatment when it's really not relevant to what the person's presenting. I'm not sure if that answered the full question, so if there's a follow-up, I'm happy to.
I mean, definitely gets at part of it. And I think the other piece of that is, so if somebody isn't presenting with that stress, and even with a careful assessment, it doesn't appear that it should be the focus of treatment. For those individuals, and perhaps there aren't many of them, so it's a moot point, but is there a different type of intervention that isn't individual? So the structural stigma are still, it's still present. It's the consequences are felt. Are there other types of intervention that we could be thinking about that move beyond the individual?
Yeah, got it. So, yeah, I mean, I kind of highlighted the fact there hasn't been until more recently, there hasn't been a ton of work on testing the efficacy of mental health interventions for individuals. But actually, in the world of institutional interventions, when you think of school-based supports, there have actually been quite a few studies of at least of the association between having a gay-straight alliance in one school, right, and the odds of depression, suicidality, and perceived support in that environment for LGBTQ youth. So, there are examples like that where you're not intervening on the level of laws and policies, but you're intervening on providing safe spaces, basically of similar others at a developmentally sensitive period for for receiving support. And like there haven't been like to my knowledge, there haven't been RCTs of the presence of gender and sexuality alliances, but all the evidence points to the benefit of having that type of support. And so, then it becomes the thinking, well, what other institutions are important in the lives of LGBTQ individuals? Obviously, there's the family, and there's been some work showing that, we obviously know that family support is one of the biggest predictors of LGBTQ people's mental health, especially young people's mental health. But like, as far as, clinical trials of family type of support, there have been a couple, and most of those have been like kind of brief and psychoeducational. But there are many other institutions that surround LGBTQ people, and all of them probably are ripe for thinking of systematic supports that could be built in.
Great. And actually, your reference to the family answers another question as well, sort of the work that's been done, or particularly for younger LGBTQ populations, the role of the family, its importance. So we have one question asking if you've done any international work in Africa, and if so, could you share experiences there working in African countries?
Yeah, I have not. But that I have not. But I obviously see the relevance of this work to many countries across the world. The materials, we've been working for the past couple of years to really finalize the materials in a way that applies, more or less, that can be adapted pretty straightforwardly across context. We've been distilling down the principles and the treatment materials into their most basic element, so that we can publish them, and then people can use them and adapt them to many contexts. And we're almost done with that. So in the next few months, those materials will be publicly available, and I hope that people will continue to use them in any setting in which it would be possible and appropriate.
And then lastly, we have a question from Dr. Walter Bochting, a colleague, I believe. So thank you for your comprehensive talk. Can you say more about the adaptation and efficacy of your intervention for trans and gender non-binary individuals?
Yeah, it's a great question, and one that I'm excited to be able to share, that that we've just we received some funding from the Fogarty International Center at NIH to take some of the work we've been doing in Romania and to specifically respond to the needs of the trans and non-binary community there. So in the past month, we met with about 30 trans advocates and trans people themselves to get a sense of what would be useful in this intervention. So we first came to the community and asked, what are the needs that you have in general that mental health professionals could respond to. And we didn't mention the equip intervention because we really wanted to just see what the needs were and what might be helpful. But as the interviews went on and the focus groups went on, we did realize that that an intervention to support trans and non-binary people's mental health in an identity-affirming way would be relevant. And so we started presenting the equip, a summary of the equip materials in subsequent focus groups, and people really seemed to think it was highly relevant. The one thing that people consistently mentioned needing to be an addition to what's not currently in the materials, besides a general trans competence and an ability to be gender affirming, was helping with concerns of gender dysphoria and be able to access hormone treatment, which in Romania mostly comes from the black market. It's one of these situations where there's basically like one trans knowledgeable endocrinologist in the country, and people who are lucky enough to get an appointment with her, can receive at least initial prescriptions. But even many of those people end up for reasons of cost, end up going to the black market for their hormone treatments. And so we're right now in the process of working with the team of providers and community advocates in Romania to think further about what might be needed in addition to this general identity affirming mental health treatment support, which the community seemed to suggest was highly appropriate, almost as is, with some general gender affirmative additions, but really thinking of how we can partner with local providers there to address this other unmet need seems to be pretty essential.
Great. And lastly, actually two questions related to the implementation portion of your dissemination of EQUIP. You noted that you had sort of been successful in training providers across the US, and you were described some fidelity measurement looking at responses to case examples, if you will, sort of taped video scenarios. Had you been able to examine any client outcomes related to the dissemination of EQUIP? So we know that the providers are, sort of scoring well, but just how does that translate into client outcomes?
Yeah, it's such a good question. I mean, it's kind of like the holy grail of these like provider training programs. It's like, oh, if you can only have like access to medical records, then you could actually see if people's if the client's mental health improved. It's a hard study to do, but there have been a mentee of mine, Maggie Price, who's assistant professor at Boston College, has a K award to do just this. So she's training providers in the Boston area and trans competent mental health care. And because she's working with a couple of clinics, she in a contained situation, she's able to have access to the client records to see if there was a prospective change in mental health. So she just started that study. So hopefully not too long from now, we'll know whether there are even further downstream outcomes in the places where it matters.
And then I think our last question just relates to if you've been able to do a comparison, either if it's sort of just anecdotal, between the asynchronous delivery of EQUIP that you described and then the kind of more traditional 10-session with a therapist delivery model. And has there been differences in outcomes or even in client engagement that you've seen?
Yeah, so to answer the first question, yeah, it's certainly something that my team has been thinking about, and we have some ideas for how we can test in a real world setting the asynchronous version versus the more costly, time-intensive one on in kind of in person or telehealth delivery. Because there's a reality of what people want in mental health care, and it's probably not an app. Like there is something about a therapeutic relationship that seems curative and therapeutic, and everyone knows it, right? I think the general population knows that a relationship with a therapist that's that is is kind of irreplaceable. And so, but it's still it's important to look at, well, given that there's so much unmet mental health need in the world, including for LGBTQ people, are there ways that we can better meet those needs, even if it means that not everyone gets the same type of costly intensive treatment. And so yeah, it's an important question, not only for the field of LGBTQ mental health, but the field of mental health studies, treatment studies in general. We are just now analyzing the data from that ICBT study, the asynchronous study. But what is clear is that, well, I shouldn't be premature, but I'm pretty sure that what we'll even see basically is that there was less engagement with the asynchronous treatment than there was in our in-person studies. And interestingly, like the therapists on the other side of it are the same people. Like the therapists the therapists on the in-person studies are also the ones on the ICBT studies. It's probably not a therapist effect. Like it is probably the fact that people, these were young people, may want a relationship with a therapist, and that itself is motivating, et cetera. But we'll know more about that very soon.
And then we have one last question, although it's anonymous. Just any thoughts on the impact of COVID on the work that you're doing, the population that you're working with? I don't know if these data were probably collected pre-COVID, but just sort of thinking about how that's impacting the way that you're working now.
Yeah. You know, I mean, there are several studies that have shown, you know, the impact of COVID on LGBTQ people's mental health, and the findings are not particularly surprising. It's that, you know, LGBTQ people were disproportionately burdened by things like social isolation, et cetera, including having, you know, more constraints on the environments they end up in, especially for LGBTQ young people. You know, when that kind of freedom and flexibility was taken away, some people ended up in places that were more homophobic, transphobic, or biphobic than where they were pre-pandemic. But it is still hard to come by good, you know, good kind of data to establish a causal impact of the pandemic on LGBTQ young people's mental health. We have some data in our Swedish prospective cohort study, but you know, you realize that when the data were collected actually matters. So the data were collected pre-COVID, and then at a period in Sweden when there was very little COVID. And so, you know, when you see that, oh, there wasn't much change in mental health, it raised the question of, well, is that just because we collected the data when there was very little, you know, when the prevalence was very low, or is it because there was really no change in LGBT people's mental health compared to heterosexual cis people's, and so it's still kind of an open question. But as far as how it impacts treatment, I mean, you know, we were doing this asynchronous ICBT study before COVID started. And we continue doing it during the pandemic, and approaches like that, you know, will continue to be important in a world of more, you know, remote access to mental health treatments. Whether it becomes normative, you know, post-pandemic is, I think, still an open question.
Well, thank you very much for your presentation today. It was great, and judging by the responses, very, very well enjoyed by the department here. And so I think if there are no other questions, we will end the rounds for today. So thanks very much, and everybody tune in for the session next week at the same time. Thanks very much. Bye-bye.
Thanks so much. Good seeing you.